I'll be talking to you today about neuromuscular junction, physiology, and pharmacology. So the objectives of our presentation is the anatomy of neuromuscular junction, the physiology of the neuromuscular junction. We'll look at the acetylcholine receptor, mechanism of transmission, and the neuromuscular junction pharmacology. So when we talk about anesthesia, always refer to the anesthesia triad quite often, and muscle relaxation forms a very important part of the anesthesia triad. The use of muscle relaxants is something that we as anesthetists do on every day basis, and it's because of that it's important that we have a good understanding of the neuromuscular junction. And as you know, we use muscle relaxants to facilitate intubation and ventilation, and also to create an environment that is suitable for surgical procedures to be performed. The neuromuscular junction is a specialized synapse that enables communication between motor neurons and skeletal muscle fibers. It translates neural electrical impulses into mechanical muscle contraction through a tightly regulated sequence of events. The neuromuscular junction consists of three main components: the presynaptic terminal, the synaptic cleft, and the postsynaptic membrane. So this is an artist's impression of the neuromuscular junction, which consists of the presynaptic component, which is what you can see at the top, the synaptic cleft, and the postsynaptic component. So starting with the synaptic component, presynaptic component, the artist has made a huge amount of effort to try and simplify this whole concept. But I want to say from the outset that in real life, the mitochondria tend to be more proximal, and the synaptic vesicles are more distal within the nerve fiber. And these nerve fibers originate from the ventral horn of the spinal cord and project axons to skeletal muscles. By the time they reach the point of the neuromuscular junction, they're demyelinated, and they are Schwann cells that make sure the health of these nerves is maintained. Within the presynaptic terminal, as I mentioned, the mitochondria, smooth endoplasmic reticulum, and numerous synaptic vesicles containing acetylcholine, which is the primary neurotransmitter for skeletal muscle contraction. There is also a very important concept called the quanta theory. So when an action potential moves down the nerve, it stimulates the release of acetylcholine. But this is not continuous. So the body has to maximize each and every action potential through what is called the quanta theory. So the quanta theory involves the mobilization of large amounts of acetylcholine in these synaptic vesicles, so that a large amount of acetylcholine is released following a single action potential. The synaptic cleft is a space between the nerve terminal and the motor end plate. So some textbooks will say it's about 50 nanometers, some say it's 20 nanometers, but what matters most is that this is a site where acetylcholine is released, and it interacts with the postsynaptic nicotinic acetylcholine receptors on the end of motor end plate. Now we move on to the postsynaptic component. This is the motor end plate, and is a specialized region of the sarcolemma, characterized by deep junctional folds which gently increase the surface area available for synaptic transmission. Nicotinic acetylcholine receptors are densely clustered at the crests of these folds, while voltage-gated sodium channels are positioned within the troughs. And that enables for efficient initiation and propagation of a muscle action potential. And this you can see on this artist's impression. Now we zero in and focus on the acetylcholine receptor. So the acetylcholine receptor is central to the neuromuscular junction. I mean, it's one of the most extremely important components of the actual action potential that occurs leading to muscle contraction. The acetylcholine receptor is found on the nicotinic, post-nicotinic one, obviously, postsynaptic nicotinic acetylcholine receptor is found at the level of the muscles. And this is what I was showing you here. So these receptors are found in the muscle, at the level of the muscles, and they are held tightly onto the muscle through a protein called rapsin. Okay. And these receptors have 5 subunits, and the 5 subunits are 2 alpha, a beta, a gamma, and a delta. That's the immature acetylcholine receptor. The mature receptor has an epsilon subunit instead of the gamma subunit. And the transition between the gamma to the epsilon takes about 2 years. Like that's from the time of birth till the age of about 2 years. That's how that transition occurs. Nobody really knows how that happens and all the processes that are involved. The acetylcholine, postsynaptic acetylcholine receptors have been investigated quite extensively, but there isn't enough knowledge around how this actually occurs. Presynaptic acetylcholine receptor has 7, has 5, also got 5 subunits, but they are alpha, all are alpha subunits. Presynaptic acetylcholine receptor, as the name suggests, is found presynaptically and is involved in the mobilization of acetylcholine presynaptically. And when you give muscle relaxants, when the muscle relaxants bind the presynaptic acetylcholine receptor, this will result in the pattern that's called a fade when you use a non-depolarizing muscle, when you use a nerve stimulator rather. So coming back to the postsynaptic acetylcholine receptors, which are the ones, as I mentioned, have been widely studied, the immature acetylcholine receptors are quite interesting in that they can also be found in adults if patients are critically ill or if they've suffered burns or spinal cord injury, and they can also end up developing receptors that are very similar to these immature ones, and they're called extrajunctional acetylcholine receptors. So the acetylcholine receptor is a ligand activated type of receptor. So it needs a ligand to bind to it. And it normally, the molecule binds, the molecules that activate acetylcholine bind to the alpha subunit. So acetylcholine will bind to the alpha subunit. And when it does that, it causes an opening of this channel. This then results in the movement of sodium into the cell, which is called influx, and the expulsion of potassium is called efflux, moving out of potassium out of the cell. So with immature acetylcholine receptors, when molecules like succinylcholine, which is a depolarizing muscle relaxant and acetylcholine agonist, what happens is that it causes the channel to open, but the channel remains open for quite a prolonged period of time in immature acetylcholine receptors, leading to a very high rise of release of potassium out of the cell, which then leads to an unpredictable amount of potassium that moves into the intravascular space. When succinylcholine binds to a mature acetylcholine receptor, the same process kind of occurs. Sodium moves in, potassium moves out, but we often expect in a normal individual a rise in potassium of about 0.5 to 1 millimole per liter. But with immature acetylcholine receptors, this could be it could be much higher. Large amounts of potassium can be released, which can lead to a fatal amount of potassium, which is hyperkalemia, and a possible cardiac arrest. That's why it's not advised to give succinylcholine routinely in the pediatric population, and also succinylcholine is contraindicated in patients who have critical illness, burns more than 24 hours, patients with spinal cord injury, and of course, patients who have documented high levels of potassium in their blood. Another important thing just to mention is that acetylcholine, when acetylcholine binds to the acetylcholine receptor, it only exerts its effects for 1 millisecond. That's why the whole process of, or the whole theory behind the quanta theories is important, because acetylcholine doesn't hang around the postsynaptic region for very long. And the reason for that is because it's broken down by acetylcholinesterase, which is an enzyme that breaks down acetylcholine. And the reason why acetylcholine is broken down is so that it prevents uh, excessive muscle contraction, which might have deleterious effects. So acetylcholinesterase helps to keep things in balance. On the other side, or on the opposite side, is succinylcholine is not broken down by acetylcholinesterase, so it tends to hang around much longer, and that's why the patients then develop initially fasciculations. That's due to repeated muscle contractions occurring at the same time, and then they get flaccid paralysis. Acetylcholine tends to stick around this postsynaptic region for longer until it diffuses out and is broken down by pseudocholinesterase. But if a patient has a deficiency in pseudocholinesterase, then they're going to have prolonged paralysis, which is known as succinylcholine apnea. So this is a video I obtained from YouTube just to help you kind of understand what actually happens. So everything that I've talked about so far, we're going to put it together, and this video helps to summarize that. So I will be going through this video and stopping as I go along to try and explain it so that you can be able to understand. So what happens at the neuromuscular junction is that the first part is we get an action potential. So this action potential moves down our nerve fiber. As a result of that, there is calcium. This then leads to our voltage-gated calcium channels opening. Remember, we talked about the fact that acetylcholine receptors are affected by a ligand that binds to them, and that's what causes the conformational change. But there are also what we call voltage-gated receptors. An example is one of them is these calcium receptors that are activated by an electrical impulse, also called action potential. So they rely on some electrical impulse for them to open up, whereas acetylcholine receptors don't. They rely on a particular molecule binding to them for them to be activated and change their conformation. So when an action potential moves down the nerve, the calcium receptors open up, and this happens extremely quickly, very, very fast. Then the calcium begins to move into the nerve fiber. When it moves in like that, there is an activation of other proteins. There are other proteins that become activated that I'm going to tell you about that then lead to the movement. That process then causes a cascade of events that leads to the migration of acetylcholine receptors to distally towards the membrane so that they then fuse with this nerve membrane here and release acetylcholine into the synaptic cleft. This is called exocytosis. You're going to see that happening now. So we have our calcium, and then we get our acetylcholine vesicles fusing, and then we get release of acetylcholine into the synaptic cleft. Once the acetylcholine receptor molecules are released in the synaptic cleft, they then move to the acetylcholine receptor, bind the acetylcholine receptor, and when they bind the acetylcholine receptor, the alpha subunit, the acetylcholine receptor then changes in its conformation. And when there's conformational change, we get sodium moving into the cell, and we get potassium moving out of the cell. So there we have sodium moving in and then we've got potassium that will move out, but it's not represented here. Potassium is not shown. That then, the movement of sodium into the muscle then activates an action potential. Okay, so not only are the acetylcholine receptors involved at this stage, but there are also other voltage-gated sodium channels that also participate in the muscle contraction occurring. So the ability of the acetylcholine receptors to open and respond to acetylcholine in the absence of activation of the sodium channels is like, if there's no activation of sodium channels, you won't get muscle contraction. So acetylcholine is central to muscle contraction, but after you get muscle contraction, you get activation of acetylcholine receptor, you also need to get activation of the sodium channels, which then also then leads to an action potential, which ultimately leads to muscle contraction. So if you don't get those two processes happening following the binding of acetylcholine receptor, there isn't going to be muscle contraction. So if there are drugs that actually block the propagation of an action potential following the binding of acetylcholine to the acetylcholine receptor, you won't get any muscle contraction. So that's a very important thing to know. So after we get the action potential, we have our acetylcholine getting broken down by the enzyme acetylcholinesterase. And remember, I said this is very important because the body does not want to get excessive muscle contraction or uncontrolled muscle contraction. So there needs to be a breakdown of acetylcholine. Acetylcholine is broken down into choline and acetic acid. These then are recycled to form acetylcholine once again through the action of another enzyme, which combines choline and acetic acid to form acetylcholine. And when acetylcholine is formed, new vesicles containing acetylcholine are then formed, and this way acetylcholine is recycled. Choline is obtained from the diet and the liver, and acetyl-CoA is obtained as a byproduct of metabolism. So the body has a way of recycling all of these molecules, and in that way is efficient. So this is the equation I was telling you about: choline, acetyl-CoA combining via the actions of choline, acetyltransferase to form acetylcholine and CoA. So when the calcium enters into the nerve fiber, the proteins that are activated and sense the movement of calcium into the nerve fiber are synaptobrevin, and there's also what they call synap2 and syntaxin. These proteins combine, and for a lack of a better word, almost like a traction force is exerted so that the vesicle containing acetylcholine is moved towards the distal part of the nerve fiber to fuse with the membrane and cause a release of acetylcholine to bind the acetylcholine receptor. This is known as exocytosis. Yeah. This is a summary of how muscle contraction occurs. So you get an action potential in a neuron. That's what I showed you. Acetylcholine is released from the terminal baton, and you get acetylcholine binding to the nicotinic receptor. This alters ionic gradient. We know we get sodium moving in, potassium going out, and an electrical potential is generated. You get an action potential in the muscle. The action potential causes depolarization along the T tubules. This then causes calcium release from the sarcoplasmic reticulum. Calcium binds to troponin C. A change in troponin C, troponin I opens and binding sites on actin. ATP and ADP in the myosin head cause thin filaments to slide on thick filaments, producing shortening. Calcium is pumped back into the sarcoplasmic reticulum. The decreased calcium causes calcium to be released from the troponin C, actin releases myosin head and the muscle relaxes. Okay, so I did not emphasize the whole part of muscle contraction because I mean the purpose of presentations may need to focus on the neuromuscular junction, but this summary from Ernie Welch is very good and straight to the point and kind of explains all the steps. Going on to neuromuscular junction pharmacology. So our depolarizing muscle relaxants are in literature is succinylmethonium and decapmethonium, but in clinical practice, succinylmethonium is the one that's mainly used, otherwise known as succinylcholine. And as I explained, when it binds the acetylcholine receptor, it leads to the opening of that receptor. Sodium moves in, potassium moves out. You get fasciculations and you get flaccid paralysis. It's broken down by pseudocholinesterase. The effects of succinylmethonium about 7 to 10 minutes. Obviously, this varies depending on the amount of pseudocholinesterase and the quality of pseudocholinesterase that the patient has, and also if the patient is deficient in pseudocholinesterase or the pseudocholinesterase quality is not as great, then that causes prolongation of muscle relaxation, or in worst case scenario, if the levels of pseudocholinesterase are extremely low, or absent, they will develop what we call succinylmethonium apnea or scoline apnea. So succinylmethonium, if a high dose is given, like more than 3 milligrams per kg, or an infusion is used, patients can end up developing what is called a phase 2 block. And there are several theories as to why this phase 2 block occurs. When you connect up a nerve stimulator in the patient, the pattern that you will get is that with the fade, which is not what you would expect when you give succinylmethonium, because typically when you connect up a nerve stimulator to monitor for succinylmethonium effects, what you do find is a decrease in amplitude in the train of 4 count, but all of the twitches are of the same height, just a decrease in amplitude. But when you give large doses of succinylmethonium or an infusion of succinylmethonium, you'll get a fade, which means there will be a progressive decrease in the twitch height that you obtain when you apply a nerve stimulator to the patient. And the reason why this occurs is postulated to be an alteration in the ATP, sodium ATPase pump. There might be a change that they suspect might be occurring, but it's not very clear all the mechanisms that are involved in the phase 2 block. Another reason is because giving lots of succinylmethonium can lead to excessive efflux of potassium. The electrolyte imbalance that occurs might be a contributor to the phase 2 block. Non-depolarizing muscle relaxants as well, these are different in that from succinylmethonium in that they compete for the binding side, the alpha subunit on the acetylcholine receptor for binding, and this competitive effect results in the inability of the acetylcholine receptor to change its conformation and open up its channel. So there is no movement of sodium or potassium out of the cell, and as a result of that, no action potential will be produced, and there will be no muscle contraction that's going to occur. So that's how non-depolarizing muscle relaxants end up causing paralysis. They also, not only do they block the postsynaptic acetylcholine receptors, but they also block the presynaptic acetylcholine receptors, leading to a diminished mobilization of a decreased mobilization of acetylcholine presynaptically. So there's also a concept called a desensitization block that can occur when using muscle relaxants, in that the acetylcholine receptor, although acetylcholine may be around or the receptor will not no longer respond to acetylcholine as it had done before. And the result of that, what then happens, you get prolongation of muscle relaxation. So in the presence of drugs in the presence of agents like volatile anesthetics, they can cause a desensitization block. That's why in literature or in textbooks, when you read, you might find they talk about certain agents that potentiate muscle relaxants. And this is part of the phenomenon known as a desensitization block. So even though acetylcholine is present in the system, but the receptor itself is no longer sensitive to acetylcholine, so the effects of muscle relaxation are prolonged. Still talking about this issue about prolongation of muscle relaxant, magnesium sulfate, and I know many people still use it for blunting, especially in obstetrics. It's used for eclamptic patients, and sometimes you find these patients need to come in for an emergency cesarean section, and they've had huge amounts of magnesium sulfate, and you think to yourself, how much muscle relaxation should I actually give to this patient? Because I know from pharmacology that magnesium sulfate will potentiate the effects of non-depolarizing muscle relaxants. And how does that happen? So the magnesium affects the presynaptic acetylcholine receptors. So as a result of that, you then get prolongation of muscle relaxation because remember the presynaptic acetylcholine receptor is responsible for mobilization of acetylcholine. So if it's affected, that means you're going to have less acetylcholine available at the neuromuscular junction and hence prolonged muscle relaxation. All right, so comparing depolarizing and non-depolarizing, I had already spoken about the fact that depolarizing you have succinylmethonium, decamethonium, non-depolarizing you have benzyl isoquinolones like cisatracurium, atracurium, aminosteroids, pancuronium, ficuronium, rocuronium. So this list is definitely not exhaustive, but it's just to give you a little bit of an overview. Looking deeper and delving deeper into muscle relaxants is beyond the scope of this presentation, but since we're looking at the neuromuscular junction, I just felt for completeness of sake, we should just look at them briefly. So also reversal agents is something that one has to consider. Again, a little bit beyond the scope of this presentation, but I still feel for completeness sake, it's important that we look at them. So the two main reversal agents that you may have been exposed to and also in clinical practice is neostigmine and sugammadex. So neostigmine is an acetylcholinesterase inhibitor. So remember what we talked about is that acetylcholine causes results, its release and its binding to the acetylcholine receptor results in muscle contraction. And in order to control or to inhibit further muscle contraction, an enzyme called acetylcholinesterase breaks down acetylcholine to choline and acetic acid so that the muscle does not continue to contract, or does not contract excessively. So there needs to be some sort of balance, and that's the role of acetylcholinesterase. So the effects of acetylcholine only last for like 1 millisecond, and it's rapidly broken down. So the use of neostigmine is to inhibit the effects of acetylcholinesterase. Its in clinical use is in our case, when you've administered muscle relaxants, is because you want to increase the amount of acetylcholine present at the neuromuscular junction to compete with the non-depolarizing muscle relaxant so that more acetylcholine can be able to bind to the acetylcholine receptor. That's the aim and of giving acetylcholinesterase. Obviously, when you're going to give neostigmine, you have to give it at a certain point when the concentration of non-depolarizing muscle relaxant has decreased to a level that when you connect up the nerve stimulator to the patient, you should be able to get a train of 4 ratio of 90% or above. At that point, you can reverse the patient with neostigmine, and to counter the side effects of neostigmine, like excessive secretions, bradycardia, you give glycopyrrolate at the same time. Or if you in your institution you don't have glycopyrrolate, you can give atropine also at the same time of administration of neostigmine. If you give neostigmine too early, you run the risk of developing what we call recurarization, which means initially, when you reverse the patient might start breathing and it will seem like the patient is okay. But after a few minutes, maybe 30 minutes, the patient will start flapping around. Patients will start telling you that they're having difficulty breathing. They might also have confusion because of poor ventilation and poor CO2 clearance, and they might end up developing CO2 narcosis. So in that case, it's important to manage and assist the patient, manage their airway. It may also be important to reintubate them if you don't have another powerful reversal agent that can completely put them in a comfortable state and completely take care of the muscle relaxant like sugammadex. So you would need to repeat the dose of neostigmine and might also consider, as I said, reintubating the patient. It's not a very nice situation, especially for the patient, because they'll be awake and they will be having difficulty in breathing, and it also increases the risk of aspiration. So it's the timing for giving of neostigmine is extremely important. There's another agent called sugammadex, which is a cyclodextrin. And the advantage of sugammadex is that it can be used to reverse aminosteroids like pancuronium and rocuronium, vicuronium, because it encapsulates the muscle relaxant, and regardless of when, it doesn't actually matter when you've given this muscle relaxant, you can get complete reversal if you give the right dose of sugammadex. So the dose is about 2 to 6 milligrams per kg. However, it varies on how deeply muscle paralyzed the patient is, and obviously the dose. So you can go from like as much as 2 milligrams per kg all the way up to 16 milligrams per kg. So if you've given a big dose and you want to reverse the patient immediately, you can give a dose of sugammadex of 16 milligrams per kg. You will get complete reversal and the patient back to baseline. In about 3 minutes, the patient will be breathing almost normally as if they never had muscle relaxant on board, and they will be able to maintain their airway. The downside, though, is that sugammadex is an expensive drug, and you would have to use a lot of vials, draw up quite a number of vials for you to get to the dose of 16 milligrams per kg, and it's not a cheap drug. So the pharmacy department may not be happy if you are always drawing up 16 milligrams per kg. The other danger is that when you give very high doses of sugammadex, you run the risk of triggering an anaphylactic reaction. Some patients have had an anaphylactic reaction. Some patients have had cardiac issues like a bradycardia, severe bradycardia following the administration of sugammadex. So you have to be careful about that. As a principle in anesthesia, don't give a drug unless it's actually required. So if you don't routinely give very high doses of sugammadex unless absolutely it's required. Most of the time, for most procedures, a dose for 2 to 6 milligrams is adequate. Even up to 8 milligrams per kg generally is adequate. But you seldom ever need to give very high doses of sugammadex unless it's an emergency where you've given a high dose of rocuronium and you need to reverse the patient because you're failing to intubate or ventilate the patient at that time, and you make a firm decision that reversing the patient is the only way to save the patient's life. Because sometimes reversing the patient with a difficult airway may not be the right course, because it may be easier to keep the patient paralyzed so that you can manage the airway better. But if a decision has been made that the only way of escape or the only way of saving the patient's life is to reverse the muscle relaxant, then giving a huge dose of sugammadex may be the most prudent thing to do. The other thing I want to say about use of neostigmine and sugammadex is that neostigmine can be used in patients with renal disease. Sugammadex, one has to be a little bit careful because it is excreted by the kidneys. So I often don't give sugammadex if a patient has got kidney issues and they are not passing urine, because it needs to be excreted by the kidneys. If the patient has got end-stage renal disease but are on dialysis, then I'm more comfortable to give sugammadex, because I know after the procedure they may be, if they are due to get dialysis, then it's okay. I know the sugammadex is going to be cleared when they go for dialysis. What if the patient has a low GFR? Can you give sugammadex? You can still give it. And neostigmine, as I said, it's safe for you to give in a patient with renal disease. You can still give neostigmine. Another question that often comes up: can you give neostigmine and sugammadex in the same patient? I'll always think of cost-wise. So if you don't need to, remember the principle: if you don't need to, then don't. But you can give it, like, let's say, for example, the scenario I talked about, when you've reversed the patient you've given neostigmine, you've given glycopyrrolate, and you still feel that the patient is not well reversed, and they are not breathing as well, they just feel weak, then in that case, giving sugammadex after that might be a more better thing to do. And we have had instances where patients were reversed at the end of a procedure and extubated, but by the time they got to recovery, their sides were okay, but they just appeared weak, like they couldn't lift up their arms, and their breathing was not so regular. And then after they get sugammadex, they do way better, they look brighter, and they actually feel like they can breathe much easier. So you can give sugammadex in those cases. So in summary, understanding neuromuscular junction physiology, pharmacology is fundamental anesthetic practice. The neuromuscular junction is complex and finely tuned synapse where subtle differences in receptor types and distributions can significantly affect how muscles respond to various drugs. By appreciating this complexity, we can tailor our anesthetic approach to different population groups, ensuring that each patient gets the safest and most personalized care as possible. All right, thank you for your time. These are my references.